welcome Dr. Prof Hossam Afify, who is going to speak to us about how to optimize source control. So Prof Hossam Afify has obtained his master degree in anesthesia and critical care in 2001. He successfully completed his PhD degree in 2006, and he also got his Saudi Adult Critical Care Fellowship in 2016 and European Diploma of Intensive Care in 2017. He is currently working as a consultant in King Abdullah Medical City, Makkah. Yeah, please go ahead, Prof Hossam.
Bismillah. First of all, I want to thank Dr. Muhammad, the organizers, Dr. Saad Mahdi, Prof Samir Ansari. My lecture actually to take less than 30 minutes, so it is the end. So how to optimize the source control? I have no conflict of interest. There is a consensus that antibiotic therapy and source control are the major therapies for severe infection. Source control has been consistently ignored by many of studies. However, the major exact rule for the source control remaining neglected in the most of the studies, only limited attention in the few literature and studies. The objectives of my lecture actually to clarify the importance of proper source control, to understand what is the proper way or ways to control the source of sepsis, to explain how much the teamwork and the proper plan decreasing the mortality, and finally to or to emphasize the importance of point of care ultrasound in diagnosis and the management of the sepsis. The medical guidelines, it is usually a summary of consensus of statement of best practice in healthcare. You obliged to know, but not obliged 100% to follow these guidelines. Surviving sepsis campaign, including the 4F, which is of controlling the sepsis, including the figure it out, fill the tank, fight the bug, and then fix the perfusion. Figure it out by early recognition, and the fill the tank by proper fluid resuscitation and the close monitoring of the responsiveness, and then fight the bugs. To fight the bug, you need to start proper antibiotic, as Dr. Adil mentioned, and proper source control also. Finally, fix the perfusion by continuous monitoring of the lactate, by continuous keeping the MAP more than 65 or keeping it perfusing, by continuous keeping eye on the organ perfusion, and plus or minus using the vasopressors and inotropic support. Based on surviving sepsis campaign, they recommend as soon as identify the source of sepsis, and as soon as do something to intervention to control it, as soon as medically and logistically practical. If there is line and you assume this line is related to the sepsis related line insertion, please secure another one and insert another line. This based on the surviving sepsis campaign. The impact on survival. The impact of source control seems to be unrelated to administration of proper antibiotic. Both are independent predictors. The delay of initiation of the antibiotics and the delay of initiation of proper source control associated with mortality. But there is a consensus that without adequate source control, antibiotic therapy have little, if any, effect. Blues published in Critical Care Medicine 2014 a study. Conclusion of this study that the delay of the source control more than 6 hours associated with increased mortality. However, initiation of antibiotic therapy associated with improved patient outcome. But he found also there is poor compliance among the critical care health providers. They are not following the resuscitation and the guidelines bundled. He also, in 2017, he published Medusa trial. In Medusa trial, he find also that any delay of the antibiotic or source control associated with mortality. Maria Martinez, she published in Spain a prospective trial about 4,000 patients. She found, despite the great severity of the condition, there is worse compliance with the resuscitation bundle. But she found that there is a decrease, markedly decrease in the mortality in the patient receives proper source control. Our lectures will focus on big three questions: who and when and how. How patient for source control, and when and how to control it. If we consider this is our paradigm for sepsis, we have a source, we have a weapon, and we have traditional enemy, which is the time. We need to answer, who is a patient candidate for source control? What is our time frame and when we should control it? And what is our tools to control this source? The first question is the source of infection. The source of infection can be not amenable, yani we have no source can be controlled by usual source control, and other sources are amenable for source control. Not amenable for source control like meningitis, sinusitis, pneumonia, infectious diarrhea, cellulitis. Most of these infections, there is no source can be controlled by usual source control, like debridement or drainage or deobstruction. However, in some other infection, like which is amenable for source control, like parapneumonic effusion, can be controlled by insertion of a drain or chest tube. Acalcular cholecystitis can be controlled by insertion of cholecystostomy drain, abscess, open and drain, and GIT ischemia, open, resection, re-anastomosis, pyelonephritis obstruction, insert nephrostomy, insert nephrostomy tube or ureteric stent. And finally, if it is line-related sepsis, you should remove this line after securing another line. This mandate head-to-toe assessment of our patient, from head to toe, from back to back, examining all holes, the oral cavity, the nasal cavity, the external auditory meatus, the anal orifices, the perineum, and should be go as a formal assessment of patient to answer the question, where is the source? The second question in our paradigm is, what is our tools? What is our weapons to fight this source of sepsis? Actually, the ideal source control method should be effective, meaning should be in by one tool, you should cover debridement, drainage, the deobstruction, restoring the function and anatomy in no time, without need of surgeon and anesthesia, without need of consent, without need of transportation of the patient from the ICU to OR, without physiological derangement as a collateral damage from our intervention. This mission seems to be mission impossible. The 5 Ds to control the source can be surgery, which is a definitive, just debridement, drainage, device removal, and deobstruction. However, the surgery is the most effective as regards drainage, debridement, restoration of the function. We have a lot of conflict as related to the consent taken, the time to intervention, and the need to transport the patient to OR, and the physiological derangement and the collateral damage related to surgery. Debridement less than drainage and debridement can be done by the debridement only, and no restoration of the anatomy of the function, less conflict, less time, less transportation. The drainage, by putting a drainage tube by intervention radiologist, it will help in drainage. Little for debridement, no role in the restoration of anatomy of the function. Consent to conflict is less. Time to intervention is less. No need to transport the patient to the OR. You can do it bedside. And finally, deobstruction. And deobstruction, it is a subtype from the definitive or the open surgery. The third question, our traditional enemy. What is our time frame? We can control the source of sepsis in it. Based on surviving sepsis campaign, They recommend controlling the source of infection as soon as medically and logistically practical. And they put a time window from 6 to 12 hours. Royal College of Surgeons, they recommend for abdominal sepsis to control the abdominal infection within 6 hours or immediately push the patient to OR if he's in septic shock. SIS or Surgical Infection Society, they recommend for abdominal sepsis time window up to 24 hours, but immediately push the patient if the patient in septic shock again. Japanese G published in 2014 in Critical Care Medicine, if the patient in GI perforation, the optimum time to shift the patient to OR within 6 hours. Less than 6 hours, you will improve mortality and decrease mortality and improve survival and outcome. Again, so we have delay of sepsis and we have greater impact of source control on survival. We need to know why there is delay. Why there is delay? However, there is a mortality related to sepsis up to 20% worldwide. The delay can be related to delay of diagnosis. Delay of diagnosis may be related to underestimation of sepsis, no formal clinical assessment of septic patient, reluctance for using point-of-care ultrasonography, use improper diagnostic tool, like asking radiologists to do CT abdomen without contrast to rule out abdominal sepsis. How to correct it? By continuous education, formal local guidelines and sepsis management, optimize the use of point-of-care ultrasonography, multidisciplinary approach. Another reasons related to the delay of intervention. Why? There is no ER theater, no availability of ER theater, no availability of intervention radiologists 24/7. Availability of source control oriented surgical, not any surgical team, should be source control or sepsis source control oriented surgical team. Instability of patient, complexity of the condition and situation. In 2014, Professor Jean-Louis Vincent created the term of sepsis team or sepsis alert team. Sepsis alert team had a lot of tasks. Insertion lines, take a sample, hemodynamic monitoring, administration of antibiotics, even initiation of mechanical ventilation, and sometimes initiation of the source control. This team not including the doctors and the nurses only, but also infectious disease specialists, radiographers, phlebotomists, pharmacists, even surgeons, depending on the local resources of your institute. Each member of this team should have a predefined task, and the leader should direct and coordinate between them. This team should be available 24/7. And there is some institutes containing what's called choke room. However, the choke room, there is the team will stay there, and this room will be equipped by all necessary monitoring devices, intravascular lines, and phlebotomy equipment. It is not only the players, but also the plan. The team coach or the team leader should put immediate goals, like how to prevent the source control, how to prevent contamination, eliminate the source, if there is source ready to be eliminated, like removal of the line, insertion of the drain, and in the same time, avoid more hazard, avoid more damage for this patient, avoid transportation of unstable patient. Case break. Please prepare yourself to answer this question. Very important for us. Mr. Donald, 70 years leukemic patient on mechanical ventilation because of hospital-acquired pneumonia. At 3 a.m., he developed new onset hypotension, no clear source of sepsis, but his abdomen is markedly tense and tender. However, with adequate resuscitation and broad spectrum antibiotics, he remained in refractory shock state with rising lactate. We started vasopressors, hydrocortisone started also. Point of care ultrasound showing free fluids, turbid free fluids, intra-abdominal, normal LV and RV size and function, 1 hour later, patient became anuric, hypothermic, high anion gap metabolic acidosis. The question now, what is the best management plan? Please prepare your answer and you can put it on the chat box. Select from these of answers the best answer. Either discuss the code status and put the patient as DNR, support the patient by all vasopressors, by carb infusion, discuss the case with the surgery team after morning endorsement, send the patient for CT. He is unstable now. Send the patient for CT for diagnosis of the source. OR, it is possible perforated viscous for exploration, lavage, resection, and re-anastomosis. Or OR again, but if possible, it is possible perforated viscous for exploration, lavage, colostomy, backing, and temporary closing. Then send back the patient to ICU for more support, and then in the morning, you can discuss definitive management with the surgical team. 1 minute for collections answers. So, the best answer is OR. Yes, it is OR, but the last one, it is possible perforated viscous for exploration, lavage, colostomy, backing, and temporary closing, and then send back a patient to ICU for further stabilization. Damage control for abdominal sepsis. The answer here. The damage control, firstly, described this term in the truncal and the abdominal trauma. They took the patient to OR in the stage. The first stage is the resuscitation of the patient in the ER. Then shifting the patient into the OR, where they do primary control of the hemorrhage and primary control of any contamination of the infection. And then shifting back the patient to the ICU for further stabilization and controlling what's called the lethal triad or triad of death, which is the hypercoagulability, acidosis, and finally hypothermia. This stage can be summarized into stage 0, started in the ER, whereas in the ER we should focusing on to manage hypothermia, acidosis, coagulation, and with BOTA goals for adequate tissue perfusion, adequate preload, adequate systemic pressure. Then shift the patient to laparotomy. When the laparotomy, they will do resection without primary anastomosis, and then temporary drainage, temporary backing, and temporary closure of the abdomen. Shifting a patient back to the ICU in stage 2 to optimize the fluid resuscitation, protective lung strategy, optimizing nutrition, and the close monitoring for the abdominal compartmental syndrome. Subsequent look or subsequent surgery can be, and finally definitive abdominal wall closure and re-anastomosis. Same case, the patient returned back to you after OR, lavage done, colostomy done, backing, temporary closing, and now he is better as regards the hemodynamics, improving in metabolic acidosis. 3 days, he started to worse again, with more drop of the blood pressure and the leukocytosis. This is abdominal drain, and the ultrasound showing some perfusion and effusion and consolidation, and finally there is infection from the wound. What is your plan? This is another question. Please, if you have the answer, put it in the chat box. The best answer is either discuss the code status, again, put him DNR, or support the patient by all vasopressor, by carb infusion, discuss the case with the surgery after morning endorsement, send the full septic screen, start vancomycin, removal line, and book for pleural drainage whenever possible. The final is the start vancomycin, remove the central line now, and pleural drainage within 6 hours by point of care ultrasonography, and then call the surgeon for possible debridement as soon as possible. 1 minute allowed for answering. Excellent. So most of us agree about the last answer is the best answer. Start vancomycin, yes. Remove the line. Here in this situation, we have a patient with multiple sources. We have effusion consolidation, we have line, and we have abdominal infection. I will give priority for the abdominal infection. Yes, it's the main cause, but I will start by what feasible. What feasible, I will remove the line, and then by my ultrasound, I put a drain in the pleural effusion. And the same hour, I will call the surgeon or surgical oriented team to put a plan for debridement as soon as possible. Thank you, Will. The role of focus in septic shock, actually, the point of care ultrasound increasing the detection of the source up to 80% within 10 minutes. Easily taught to learners. Even the novice ultrasound users, without any previous experience in the ultrasound, they can do perfect ultrasounds after focused training course, decreasing a lot the length of stay, especially in the ER. In the daytime, the decreasing length of stay down to 11%. And after hours, up to down 20%, decreasing in length of stay in the ER. We have approach. Yes, we have approach in the septic shock for using an ultrasound. Remember the 3D. 3D is the diagnosis. The point of care help us in the diagnosis, help us in the deranged physiology correction, and finally in the drainage. In the diagnosis, we need to ask ourselves, it is septic shock or other types of shock? So we need to rule out by ultrasound other types of shock. The second D, the deranged physiology correction. By ultrasound guided fluid management, as Dr. Hisham mentioned, the patients needs more fluids according to the indices and the insertion of central line. Drainage, source control, pleural drain insertion, cholecystomy drain, acetic drain insertion, arthrocentesis, LB sometimes. Professor Daniel Lichtenstein, he is the creator for most of algorithms based on point of care ultrasound. He created what's called the blue protocol in respiratory failure and the false protocol in the shock intubation in the ER. This algorithm showing the integration between both the blue and the false protocol. First of all, if your patient is collapsed, so either it is in ER or in the ICU, use your ultrasound machine to rule out the obstructive shock. Rule out tamponade, pulmonary embolism by reviewing the RV. Is any RV collapsibility during diastole, and compare the size and the function between the size of the RV and the LV. Then the lung ultrasound to rule out pneumothorax. So the first question is rule out obstructive shock. Then assessment lung for B lines. If there is extensive B lines, most probably we are speaking about cardiogenic shock. If there is no B line and there is no clear signs of obstructive shock, and we have only A lines by the ultrasound chest, we are most probably speaking about hypovolemic or distributive or septic shock. Give fluid to the patient, either fluid challenge or passive lake raising. If the patient markedly improve, it is most probably hypovolemic. If it is little bit improvement of the hemodynamics and soon B profile eventually generated, it is most probably septic shock. The second, if the septic shock, where is the source? The source can come from this algorithm, another algorithm. Alonso and his colleague in the emergency medicine, he published this algorithm. To summarize this algorithm, we need to examine 4 areas in the body. We need to examine the heart, the chest, abdomen, and then the soft tissue. The heart, up to 84 sensitivity of the point of care ultrasound to detect the vegetation more than 10 millimeters. Lung ultrasound, early pneumonias, there is B lines and subpleural consolidation. Later can be there is air bronchogram or even what's called shred signs and dynamic bronchogram also. Abdominal examination to rule out acalcular cholecystitis. The BOCUS highly sensitive and specific to detect acalcular cholecystitis also. The appendix they found, especially in pregnancy and especially in the pediatric group, there are high sensitivity of using BOCUS in detection of the appendix. Pseudo-kidney sign as a sign of diverticulitis. It is very important to rule in diverticulitis by using BOCUS as a bedside. Finally, if there is hydronephrosis like this, can be source of sepsis and it can be managed easily by insertion of ureteric stent or nephrostomy tube. If there is no clear source in the heart, kidney, heart, abdomen, and in the chest, please check the soft tissue. Soft tissue to diagnose cellulitis or even necrotizing fasciitis. There is two signs here, the cobblestone sign in the soft tissue in the cellulitis and what's called dirty shadow in necrotizing fasciitis. Take home message. With high respectability for the 1 hour bundle, we should change our mind. We change our mind from 1 hour bundle to what's called extended 1 hour bundle. So 1 hour bundle including lactate, insertion of line, give fluids, antibiotics, vasopressors, but we should extend our mind and our thinking to what's called extended 1 hour bundle, which include patient again. Please go assess your patient from head to toe, from back to back, every holes, and then assign your players, put a team, assign the task for each team, and put a plan. What is the early goals? What is the goals should be done now, and after 2 hours, and after 3 hours, and after 4 hours. BOCUS and BOCUS and BOCUS in the drainage, in the diagnosis, in the intervention, use the BOCUS everywhere. If the patient collapsed again, reassessment him by BOCUS also. Finally, try to change your institute and your hospital policy and protocol, and put a plan for education as regard teamwork, simulation, and point of care ultrasound. Thank you very much.
Great.
Thank
Fantastic.